Good afternoon, distinct chairpersons and distinct audience. I have given a task to discuss about a guide extension catheter. I'm Tamzeed. A guide catheter extension system actually increases the guide backup support and is crucial in complex PCI procedures, particularly in case of severe calcification and toxicity. So guide catheter extension can provide coaxial guide extension over a monorail system like a balloon. So generally available guide catheters are GuideLiner V2 catheter, which was FDA approved 2009, GuideZilla Boston Scientific, it was approved in 2013, Telescope Medtronic in 2019, and Guidian, not yet available in the US and Bangladesh. We mostly use GuideZilla in Bangladesh. So this is a GuideZilla catheter. Looks like it has a push rod and the cylinder. All the catheters are actually similar configuration. They have a push rod and the cylinder. GuideLiner has 150 centimeter available, and there are different sizes are available. GuideLiner 7 French, 6 French, 5 French, but GuideZilla is only 6 French available. So an application of guide catheter extension, it is to increase backup, can be used to bypass calcification and toxicity. However, this requires blood vessel and lesion preparation. To limit the contrast in renal compromise on heart failure patients, it can be used in situ in a reverse cart with you get the wire inside the extension catheter or anti-dissection reentry in situ. Also thrombus aspiration in STEMI, used in presence of various previous transcatheter valve where difficult to engage guide catheter, you can use a extension catheter inside and post-TAVI patients. There are other offline uses, particularly if you have a perforation, taking a covered stent is difficult with a simple guide catheter. You may use an extension catheter to solve the problem. Pitfalls, it itself can cause coronary dissection, wire and push rod twisting if the size is different from the catheter, mother catheter itself. There's difficulty in stent advancement, rewiring, ischemia, and air embolism. So 10 technical tips to minimize the risk of guide catheter extension related complications. Number 1, avoid advancing guide catheter extension against any resistance, especially in a setting of steep angles. Avoid engaging guide catheter extension in the presence of ostial branch disease. Avoid engaging a 6 French guide catheter extension in a vessel smaller than 2.5 millimeter. Manipulate the mother guide catheter engagement to optimize the direction of entry of the child catheter into the coronary branch. If possible, deliver the guide catheter extension over the shaft of the coronary balloon. It's a balloon technique you have. Sometimes you take the balloon in and inflate a little bit and then deflate, and it automatically sucks inside the guide catheter, extension catheter go inside further. So this is a diagram of a guide catheter, extension catheter, guide catheter, and it's followed by extension catheter. You can see there. And this is a mother and child, and also this is a balloon supported progression of guide extension catheter. So my first case is a 51 male female, with strong family history of heart disease, came with exertional angina, and that was his coronary angiography. Showed a lesion in the long lesion in the LAD. And there is some lesion in the ostium of this, distal left main disease here, as you can appreciate here. So we wired, we ballooned. Then of course we wanted to take the stent, we failed to take the stent there, so we had to use a extension catheter. This is an extension catheter, you can see there, and deployed the stent. Then of course there is some plug shift proximity, as you can see there is some lesion and plug shift in the distal left main, so we ended up with another stent here, of course, for left main to LAD. So that's a complication. It may happen with the stent, and of course we have to solve with the second stent and a port for final optimization and good result run off afterwards. Okay. My second case, a 61-year-old male with a cabbage in 2005, Lima to LED, venous graft to OM, diagonal and right coronary artery. He presented with non-STMI and post-MI angina. The angiogram was done in another hospital where the left-sided grafts were all patent with occluded venous graft to the right coronary artery. So this was the anatomy of right coronary artery. It is a long lesion from in the mid-segment to the RC to the PDA as well. You can see long lesions. And we wired it, but failed to take the balloon even without a support. So we have to take a microcatheter in. And you can see it's a quite deep set in microcatheter. Not a micro, sorry, extension catheter inside the RCA. Only then we could possibly put the balloon there and dilated the vessels with the NC balloon. And then, of course, also put the stent with the support of extension catheter. It was Guidezilla, of course, and another stent in the mid-segment. And that was the final result. So for a complex PCI, especially in vessels with calcification and toxicity, a guide extension catheter is required. However, it should be used gently and without a forward resistance. Thank you very much for it.
Thank you. Question regarding a guide extension catheter?
I think it was a fantastic case and you showed a great use of guide extension. But in the second case, if we choose an AL guide,
yes,
it would give better support and you may not require guide extension.
Yeah, possibly, because we took anyway JR catheter.
Yeah.
So we didn't want to change it. We all wired with the JR catheter. So we took a extension catheter instead.
So in such case, upfront, I generally use an AL guide.
Yeah,
so it gives good support.
That does give a better support,
yes.
Of course.
Thank you.
Thank you.
Thank you.
So actually, when I used to go through the right radial, the RCA coronary, it is very much difficult to get a good backup support because of angulation. In that circumstances, which method? Do we go for M+, or we'll use a bigger curve, or we'll go for guide catheter extension? Which one is better?
Yeah, of course. M+ you can use in the right radial. It's no problem. It's coaxiality with the right radial is good with the right catheter engagement, either GR or M+. M+ does give a better support. Yes, sir?
You know, the AL1 issue is a double-edged sword. AL1 gets in, but if it gets out, you then again have to rotate it. It doesn't go back in easily. It has multiple issues around it, and of course, if you've got a smaller orifice, there's a high chances of dissection as well.
That's right, sir. That's right. That's also AL problem.
So, you know, I think I love it for CTOs, but I don't like it for anything else. And I think the guide extension is a very safe and elegant technique to make sure that less dye and maximum backup happens at a very distal lesion.
That's right, sir.
So for CTOs, I love AL. But for any other thing where it's only for support issues, then I'd rather have elegant and safer issues for it.
Thank you very much. Thank you, sir.
And when guide extension is used so deep like that he used in the right coronary, that is the 5 frames, so chance of developing ischemia to the patient when the patient has got good myocardium. So that is an issue if the procedure is long.
So you must remember that if the vessel is large, these guiding catheters sit very elegantly deep into the vessel and are able to give you less contrast on a distal vessel OCT. In fact, you can actually do a distal vessel rotational atherectomy very easily because it goes through all the proximal curves. The burr goes and just delivers distally. So I must tell you, it's got huge advantages. You obviously are not going to use it in a very small vessel and cause ischemia. You will only use it, bring it down, pass it down, and then do its job, and then come back. By the way, in many instances, even of upgoing RCA, Once you get your wire down, and once you get your guide extension down the first curves, you again become very, very simple. Actually, it's one of the most useful tools for delivering devices distally, even if you have a backup proximally. You must remember that you may back up, but you may have curves, tortuosities, calcification, many things happening in the middle where just backup alone doesn't matter. What matters is how do you get across those bends and calcified tortuosities, which guide extension allows you to better. So backup alone is not necessarily an issue. Backup alone is an issue in CTOs, but backup alone is not an issue if the whole vessel is patent, tortuous, and calcified.
And the latest use, sir, about guide extension in the structural heart for coronary protection. It is very important to have the coronary protection when you are doing, then the guide extension has to be used along with the guide catheter, so that when you are retrieving the stent after you have deployed, then it doesn't get trapped in the calcium.
Yes, sir. There's a still deformation chance there.
Yes. No, the stent can get the stent can get trapped in the sinotubular junction if it is small and calcified.
That's right.
So if you have the guide extension, then you can come everything out with the guide extension, and the guide doesn't need to be injuring or going deep inside the left main ostium.
It's a very useful tool. Actually, it's increasing its
it's a very protective tool if rightly used, and as sir was saying, the safe steps. I mean, it's always better than using an AL.
Right.
A guide extension with your normal catheter would keep your artery safe, ostium safe.
So ALs for CTOs and everything else, guide extension. The other thing is, of course, don't forget the anomalous coronary arteries. Don't forget those huge aortas in which you get your guide near but can't get it into the ostia. You can just slither a wire down, slither a balloon, and get a guide extension to extend your guiding catheter. Same thing for anomalous coronary arteries. You haven't got an axial guide support, but you can still get a balloon and a wire down and then get guide extension, and you have a much better, suddenly you're sitting much better into the ostia of the anomalous coronary artery.
That's right, sir. So without fully engaged, you can put the extension catheter inside and solve the problem.
In your first case, you said that it is plaque shift. I think it is guided catheter-induced dissection. In the first case, when you put a second stent, there is a proximal dissection. Probably it is due to the guide catheter extension.
Yeah, of course. We still have to use
Both may be possible. That may be the related
Yeah.
to the guide extension. Maybe the plaque shifting might be.
Okay, thank you very much, everyone.
And also guide extension reverse card pretty much is the default these days. I mean, I have to talk about that. In CTOs, when you're doing reverse card, it's so much easier to do it with guide extension reverse card. So, yeah. Thank you very much for the wonderful talk. Really appreciate it.